country where we are right on time. It is 45 minutes after 4 with almost an academic quarter. So please come here. Let them settle a little bit. Wait, do you have the questions? No, I have just the last speaker.
She's not here?
She's here. She's standing already. Yeah? So you tell. Yeah? Okay, so we continue our tour around the world, and we move now to Arabic countries to see how palliative care is developed there. And we have our first speaker after the coffee break, AzzaHassan from Doha, Qatar. Welcome, and the floor is yours.
Assalamu alaikum. I would like at first to thank the organizing committee and the academy for inviting me to share and participate with you my experience. At the beginning, I would like to tell about my story. Originally, I am from Egypt. I worked as an oncologist for around 15 years. And after the doctorate degree, I shifted my career to the palliative medicine. Till the period of 15 years, I don't know anything about the palliative care except if the cancer patient presented late and nothing to be done, so we can say palliative care or symptom management only. And it was not like a specialty for me. And then I got a chance to travel to Saudi Arabia. And in Saudi Arabia, there is a specialty named palliative care, and I don't know at that time also that I will work in a different specialty from oncology. And I worked for 6 years at King Faisal Hospital in Riyadh, and then I moved to Qatar to build the service of palliative care in Qatar. So at the beginning, my presentation, I will talk about a small introduction about facts of palliative care, then culture and religious factors, trend in Western countries and trends in Arab countries, and some model from EMRO countries, and the trend in EMRO region, and if I have time, I can discuss a few cases. So palliative care is focused on improving the quality of life for patients and their families. For most clinicians and patients, the discussion of palliative care is still a difficult topic. It is complicated by both clinician and patient belief system, which are frequently heavily influenced by the culture and religious upbringing. Based on the estimate of WHO, each year around 377 adult people of 100 population over 15 years, and around 63 children out of 100 population will require palliative care at the end of their life. Globally, in 2011, around 29 million people died from disease requiring palliative care, and the estimated number of people in need of palliative care at the end of their life, around 20 million people. The biggest proportion, around 2/3 of the patients require palliative care in the elderly group, above 60 years, 1/4 in the middle age group, and less percentage in the children age group. So each year, an estimated 40 million people are in need of palliative care, and surprisingly, around 78% of them in the low and live in the low and middle income countries. WHO member states are grouped in 6 regions, and I will focus on the EMORO region, which is the Eastern Mediterranean region. Worldwide, as a fact, only 14% of people who need palliative care, they receive palliative care. And what about the other? The others, they are not receiving palliative care, and one of the barriers for that is either medication, unavailability of the medication, or a strong barrier to, for the opioid medication, and the other barrier, lack of the training and awareness about the palliative care among the health professionals, which act as 2 barriers that prevent the access easily to the palliative care. According to the also the WHO report in 2014, they divide the service ranking of the palliative care service into 4 categories. Level 1, there is no report about the palliative care, and then level 2, there is some building, like some services of palliative care, and at the end, level 4, there is like well-integrated palliative care in the health system. Several different religions, and moving to the topic about culture and religious factors, several different religion and culture has been evaluated for their impact on the perception of the palliative care, including end-of-life discussion, the effect of the religion, sense of destiny, quality of life, and process of preference regarding end-of-life decision-making varies from nation to nation. Although the need for comfort, peace, dignity, and presence of loved one at the end of life is universal, still unique aspect of culture and beliefs can play a significant role in providing the palliative care by palliative teams. Many factors influencing the person cultures and therefore choices about the end of life care. Worldwide, we found that ethnicity, geography, language, value, social circumstances, religious and spirituality, and gender can act as a factor in decision about the end of life in the palliative care. There are certain cultures influencing the choices about the types of support at the end of life, such as whether or not to use resuscitation measures, using opioid and other narcotic medication, and even medical intervention if they need intervention at the end of life, feeding tubes, and withholding the nutrition or hydration at the end of life, which is different from person even to person, from family to family, from nation to nation. There are certain cultures within the society preventing to disclose the diagnosis for the family, and also rather insisting to discuss the condition of the patient, not to the patient, but with the family member, key family member, not all the family member, the key family member. Are they insisting about that? The culture can influence who is with the one at the time of death, and whether the patient wants to die at home, in the hospital, or in the hospice facility. Some cultures treat the death with utmost reverence, while others prefer to celebrate life before it. Other culture has fear from death. Communication with the patient and family regarding their culture belief will help a lot to provide palliative care. I will move to the from the publication and from the articles about the maybe the practice. Maybe it's true or it may be wrong, but in Western societies this has become medicalized. They all and curative procedures or advances of medication are often prioritized ahead of the palliative care. The cure at all cost of attitude of physician, along with the strong religious view that many families hold the life often complicates the end of life management. Also, in the Western culture, there is recognizable lack of acceptance of death, leading to reluctance in seeking the end of life care, as Western culture often tries to deny death as a natural process. This may create an atmosphere where some people are unprepared for their own death or death of the loved one. In many of developed countries in North America and in Western countries, a great stride have been made in the treatment of cancer. Public awareness, increased advancement of treatment modality, anti-cancer therapy, and that led to increasing number of survival, which are growing rapidly. And concomitantly, advances in the palliative care has also taken place a little bit slower, but unfortunately, this is not what happening in the low and middle income countries. I will move to the EMRO region, which is includes 22 countries, Arab countries that contained in most of the Qatar, Saudi Arabia, Jordan, and other countries, that they have variability in the population, in the size, in the income, and in the Human Development Index, and the resources and health outcome also. So I selected, I can't go through the 22 countries, but I would like to share with you when I moved from Egypt in 2002. I had no idea about the palliative care, and there was no at that time any services of palliative care in the majority of the Arab countries, except Saudi Arabia, who has at that time well-developed palliative care service, and it was the nucleus to start and distribute the leaders everywhere to start the palliative care. So I will talk about the 4 model of palliative care in Saudi Arabia, in Qatar, and in Jordan, and in Lebanon. So as I mentioned before, there is marked difference in the population size, in the service area, in the healthcare, and resources also. So in Saudi Arabia, the first palliative care program started at King Faisal Hospital in 1990. And over the past few years, there has been marked increase in the number of palliative care services in around 20 institutes, and in oncology center, they established palliative care services with inpatient beds and consultation service, along with the home care service also. And like milestone regarding the services in Saudi Arabia, in 1990 started the palliative care service, and in 2000 the first fellowship program, training program in palliative care, and in 2010 existence of more than a comprehensive cancer center in Saudi Arabia that integrate palliative care services in the hospital along with the home care program. And in 2013, accrediting body approved the fellowship program. So a lot of graduate of fellows that they are now running the services and opening new services for cancer and also non-cancer conditions. And in 2018, recently, Saudi Palliative Care National Clinical Guideline for the Oncology distributed for a guideline for all the palliative care symptoms and to be practiced in everywhere in the oncology centers. Also, the hospice was very strange in our community, in Arab community, because hospice means that the family cannot cope with the patient at home, and this is shame for the Arab culture to take care of the patient at the end of life in another hospice. But it was, for me, very surprising that even in Saudi Arabia, they started to accept the idea of hospice, and the first hospice opened at King Fahd in Riyadh Hospital, which is a hospice. Moving to Qatar, the service in Qatar, this is Doha, the beauty capital of Qatar. The first and the only palliative care service started in 2008, and I started the service in the cancer center because I selected the cancer center as patients, they are suffering a lot. So we started the service for malignant condition because I was the only one to start the service, so and to be among the oncology patient, which is the preferred specialty. So I started the palliative care in the cancer center, in the adult cancer center. And it was growing, and I have like to build the model from consultation service at the beginning, seeing the patient and giving awareness of all the healthcare provider about the palliative care, which and also to correct the misconception about the palliative care, which is not care of dying patient, but it's a comprehensive care and holistic care to the patient and the family. And now in the 10 years, believe me, there is a big difference in the palliative care service in Qatar. We have a dedicated palliative care unit, 10-bed luxury unit, providing the care for the patients, Qatari and non-Qatari. But unfortunately, the length of stay is still big because we don't have access to the hospice or chronic care facility till now, but it's also in the agenda. And also we started to have the fellowship program in 2017. It's an approved fellowship program, and currently we have 2 fellows. And as in the Gulf region, the majority of the patient, the majority of the population, like from a quarter to 1/3 of the population, they are from the national, like in the Emirates and Qatar and the others. But the other, the majority, they are population from everywhere, are more than 60 nationalities. So we are taking care of diversity of population. So as I mentioned, we reported a length of stay among our patients to be 30 compared to the Europe and to US, which is less than us, because we have lacking of other facility like chronic care facility and hospice facility, but we are working on also hospice project. And around 85% of our patients die in the palliative care unit. This is like the graph to show the Qatar has the length of stay, the longest length of stay 30 compared to Saudi Arabia 24 and the other US and Canada in the range of 10 and 17 days. So this is like photo for our unit, the bed in our unit. And this is like also a wish which will happen at the end of this year, to study the end of life care from the Islamic perception, and it will be under the umbrella of Ministry of Health. And now the palliative care on the top priority in the health agenda. It was on the cancer in the cancer agenda in 2012 up to 2016 as a cancer strategy, but it moved now to be in the health agenda end of life care, which is now changed from palliative for cancer only, but also palliative for everyone. Moving to Jordan, which is another country and another also story regarding the palliative care. The palliative care started in 2003 as a project. Also, and it was started as a program at King Hussein Hospital. And also Jordan faced as a beginning barrier, but they are overcoming this barrier. And the beauty of the also Jordan, there is like palliative care as in the private sector. So in the private sector, there is one famous doctor named Dr. Bushnaq, who is running the own private palliative care in the community, and also education. This center acts as education for the nurses and the other allied health professionals. And also in Jordan, they succeed to have the approved Jordanian Medical Council approved the accreditation for Department of Palliative Care Medicine at King Hussein. And the postgraduate, the fellowship is 2 years. And after the fellowship training, also there is a recognition as a subspecialty. So there is accreditation, which is a big jump in the career. In Lebanon also they started, it's a recent palliative care started recently in 2009 by 2 non-governmental organizations, and in Lebanon the palliative care started as home care or community care, so they started the program as community service, and currently there is palliative care in the American University of Beirut. There is also palliative care service as inpatient and community palliative care services, and there is a growing of the project. And in Lebanon, in the last mosque, there is like Atlas of Palliative Care in the Eastern Mediterranean region published and presented during the mosque last year. So regarding the culture and in the Emiro region, there are like we are accepting as Muslims, we are more accepting and with the death, and we live like realize that death is inevitable event, such as an attitude has an impact on how to deal with the patient and their family and their view about the death, and knowing what lie beyond it. And in Islam is the dominant religion in the Middle East, and in the Muslims community, they have an illness represent an opportunity to enhance the Muslim degree or expiating personal sin. Yet the Islamic teaching encourages the Muslim to seek treatment when they fall sick, as it believes that Allah did not send down sickness, but rather medication for the sickness. And the concept of euthanasia among the Muslims is prohibited, and it can cause great distress in the region. And close family member in the Arab countries, because each family they have a big number of family members, so family members are more often directly involved in the decision-making process, and it takes a responsibility according to the order. The parents, the spouses, and all the children in descending order have the greater decision-making. So when you are tackle the Arab people, you should know who can take the decision maker or who is the decision maker in the family. Islamic teaching also encourages the community member to visit the sick patient, so we can accommodate many number of visitors during the hospitalization.
Dr. Azza, time is up. You will have to conclude in a minute.
Okay. How many minutes or I could, how, we don't? 1 minute? Okay. Also, the use of the medications that can affect also the conscious is in Islam is prohibited, but Islam also approve, or we have like in Sharia, we have like approval to use the medication, including the opioid, in treatment and relieving of suffering. And while discussing the prognosis of the loved one, Muslim families are skeptical about the receiving clear-cut message and rely always to Allah, God's hands, and we are not to predict the fate of the patient. Such response largely due to the Islamic belief that the life expectancy of every person is only up to Allah, who is the one to determine the time of death. And families, however, are very appreciative being updated to the patient condition, which is very important as the end near to the end, to tell the family member about the sign and symptom of impending death, to prepare the patient and to prepare the family for spiritual rituals, and to make their practices according to Islam. This is the end, because I have no time to discuss the cases. Thank you so much.